have a 2 centimeter, perhaps, safety margin. How do you proceed?
I think we never have 2 centimeter margin, especially for tumor of the sinus and paranasal sinus. So we have to think that we have close margin. And that's why what is questionable is adjuvant treatment after surgery. I read your paper about the topical treatment for the patient, and maybe it could be useful for in situ melanoma of the mucosa. And I think we have to go further on this kind of experimentation. It's only a case report, but we have to go further.
Well, as far as melanoma in situ or lentigo maligna, the guidelines that we follow is a 0.5 centimeter margin of normal skin. The other thing that the case that you just brings up is that even though these guidelines are out there and have been shown or proven through controlled clinical trials, in the head and neck, that's often not possible to follow them. Like in that patient, you can have a 2 centimeter margin on the forehead, but then what do you do with the eyelid? Or if you have a lesion on the, near the oral commissure. So we find ourselves relatively often compromising on the extent of normal skin that we remove because of the proximity of important functional and cosmetic structures such as the eye, the nose, the lips. And what's interesting about melanoma of the head and neck is if you review the experience of many institutions that have been doing this for years and years, we do not have a problem of local recurrence, for the most part, with cutaneous melanoma. It's a different issue with mucosal melanoma. So the message to take home is that these are guidelines, and they are to be taken into account. But there are instances when you have to do less than that, and when you do that judiciously and helped with the help of your pathologist and as much as it is possible, I think we can get reasonable results.
Therefore, there are also exceptions in the guidelines. In facial melanomas, micrographic control of surgical margins may be preferable, like Mohs surgery. Out is out. So you make sure that the depths and the margins are out, and that's enough. And this allows reduced safety margins and conservation of tissue. That is what it says, and I think we can agree with this, especially in the head and neck area and also in the mucosal area. That is would be such a microscopically controlled surgery where you make sure that the margins are all out, and then you can do these small flaps, and usually you get very nice results in the face. Now, if it's not just in situ, if it's a more advanced melanoma, there are many papers on the role of postoperative radiotherapy in mucosal melanoma. You also mentioned that. Are there any thoughts about this?
Okay. Can I go back on the previous?
You can go back, sure.
On surgical margin for melanoma. I think we do not use fully the PAT result on what we remove, and we do not analyze very carefully the margin, and maybe we can improve the PAT analysis of the margin for melanoma using extensive immunochemistry analysis of this margin or molecular analysis of this margin. And as I know, I don't know if there is a ongoing study on that. Maybe you heard about that, no?
In mucosal?
No, in cutaneous melanoma.
Well, especially in amelanotic types, we use immunohistochemical stainings with Melan R, with S100, with HMB45.
Yeah, but try to have when we have to deal with close margin. So I can have 2 centimeter margin. Maybe we can use PAT analysis of this margin. Say, okay, I have to remove more or not. I don't know if there is studies about that.
To my knowledge, not. I don't know if in the audience is there any.
Well, I would offer two comments in that regard. And one is that the usefulness of immunohistochemistry in assessing margins, I think it's great. However, the problem is that so far we don't have a practical application of it in a quick turnaround, frozen section examination. There were some studies about 3-4 years ago using HNB45 and Melan-A and a frozen section technique, and they reduced the time to about 45 minutes. But I haven't seen that duplicated anywhere else, and so that's not widely available, and it's a limitation for it. I think when you use most micrographic surgery for melanoma, and when you the thing to be careful about there is the reliability of frozen section examination to diagnose melanoma and to assess melanoma margins. Keep in mind that there have been some very interesting studies that have shown that a negative frozen section for the most part can be trusted, because it correlates well with the results on a permanent section. But a positive frozen section has to be taken with a bit of a grain of salt, because in about 27% of those patients, the permanent section reveals no presence of melanoma. So with those caveats, most microsurgery and frozen section can be used.
Fine.
There is a question.
Yes?
I would like to support what Dr. Medina said, and I think with about 90% local regional control for melanoma of the head and neck region with surgery plus minus radiotherapy, the local recurrence isn't really our biggest problem. But we do run into this controversy about frozen sections, and we have 3 or 4 dermatopathologists on our staff that will not read pigmented lesions on frozen sections. So in my practice, I tend to excise, and if it's going to require a complex reconstruction, I delay that for 2 days while the pathologists hurry their reading on a permanent section, so that we can either excise new margins rarely or more often proceed with the reconstruction. But it always, we have this one extreme, and then I don't know where to put that with the use of Mohs surgery on the other extreme, that some people are very comfortable doing both the surgery, the pathology, getting immediate answers, and recommending narrow excision. So perhaps you as a dermatologist could speak to that.
Well, in the facial skin, it's not such a problem. And we even wait for the paraffin-embedded H&E stains to be sure that everything is out, and do it in a 2-step procedure. But the interesting thing is how to proceed in the mucosal area, and it might be just not practical. And that is because our next question, if you are not sure whether everything is out or if it's a more advanced melanoma in the mucosal surface, how do you proceed with radiotherapy? Are you doing this or not, or is it a standard in your opinion?
I think we need to make a bit of a distinction with mucosal melanomas. We have the mucosal melanomas in the oral cavity, the majority of which occur in the palate and in the alveolar ridge, which behave somewhat differently than the mucosal melanomas in the nose and in the paranasal sinuses. And I think in the oral cavity, we tend to, all of them, we tend to excise them in as best as we possibly can. And we do a good job of that in the oral cavity. In the nose and paranasal sinuses, we consider ourselves very fortunate when we catch the melanoma early, and we can get clear margins around it. And more often than not, we prescribe postoperative radiation therapy. Because if you look at the literature in a historical context, you will see that up to 15 or so years ago, the series published on mucosal melanoma hardly had any long-term survivors. The mortality was horrendous. And we have begun to see some progress in some survivors only when we added radiation therapy, which brought about better local regional control, which is essential. Once you have a recurrence, then the lymph node metastases begin, the distal metastases begin. So we have to strive to obtain local regional control.
Okay, thank you. I think we have to change with the topics to proceed with the time. And One thing which is clear, elective lymph node dissection has no role today in melanoma management, but sentinel node biopsy is of course performed. And again, this is very demanding in the head and neck area, and might also pay special attention to the parotid gland. But there's also a January paper now in head and neck, just recently published ahead, with the dilemma of clinical node negative head and neck melanoma, outcome of watch and wait policy, elective lymph node dissection, and sentinel node biopsy. And in this systematic review, the conclusion is no survival advantage of either END, which was known already, or sentinel node biopsy in patients with clinical node negative head and neck melanoma of intermediate thickness. So the question is, shall we abandon sentinel node biopsy when there is no survival benefit? And if not, should completion lymphadenectomy follow positive sentinel nodes? How do you manage these patients? Professor
I have
Kailols?
one slide, if we could get up that one slide.
Yes.
There's always level of evidences, and the scale goes from 1 to 5. And I will now present level of evidence that is 6. Ask your friends. And this is exactly a controversial question. What do you do? On the left upper side of that slide, it's shown that sentinel node biopsy in a leg is very easy. You see the staining, and that is implemented. And in the ARTC melanoma group, we discuss a lot what to do with head and neck melanomas, cutaneous melanomas. And so we asked around Alessandro Testori from Milan, the chair of the surgery subcommittee, sent out questionnaires. 75 questionnaires were completed from different large institutions in different countries. What would you do in case the sentinel node is positive? That was the question. And then the charts are divided in ERTC melanoma group active institutions and probationary institutions. And so the red bars are what would be done if the sentinel node is macroscopically positive. Then most of the centers would go on to modified radical neck dissection. If it's microscopical positive, most of the centers would still go ahead and do modified radical neck dissection. Then if it's only immunohistochemically positive, then most of the ERTC active institutions would not go ahead and do modified radical neck dissection, but only limited neck dissection, whereas the probationary institutions, most of them would still do modified radical neck dissection. And then in melanoma, because we know that it metastasizes so early, even PCR findings are taken into account. If the sentinel node is by PCR only positive, even some centers would do at least limited neck dissection. That is what people do in these 75 institutions. And nothing of this is backed by evidence. And in the melanomas of the other sites, we know that sentinel node biopsy is done in order to stage the patient. In a case sentinel node is negative, its prognosis is excellent, and in case positive is not so excellent. But everything beyond that is again uncertain. And I'm pretty much surprised that extensive surgery is done to these patients, and the question remains, does this change the outcome?
Yes, therefore, in our oncology, dermatology, oncology, and surgery group, we do currently a study comparing those patients which are sentinel node positive. One group is randomized, and they are followed by completion lymphadenectomy, and the others just by watch and wait. Because by doing this lymphadenectomy, there is a certain morbidity, and we don't know if we benefit the patient as compared to a wait and see policy. And the statements of our consensus finding should be performed in melanomas thicker than 1 millimeters. It should be performed in centers where both operative and nuclear medicine teams are experienced. And the next statement, sentinel node biopsy is considered a supplementary staging procedure because of its prognostic value, but has no therapeutic value. And with regard to the head and neck, modified neck dissection does not bear a higher risk of nodal recurrence and is considered the appropriate treatment in microscopic disease. Most of these centers obviously